Hello and welcome to the Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro. Today I have with me Dr. Frederick Schiffer. He's a developmental biopsychiatrist who has a research program going. He's got some very interesting points to discuss. He's at McLean Hospital and Harvard Medical School. He's the founder and CEO of MindLight device company. He also has been in private practice in psychiatry for over 30 years. And he brings to the table today dual brain psychology for the treatment of addiction and other psychological issues. Thank you for joining us today, Dr. Fred.
Hello.
This topic, you've been studying it for how long?
I would say I had some ideas that were the very beginnings of it in the 80s. And then in 1990, I reread the split brain studies and saw a connection with what I had been thinking about. So I would say, well, I've been working on it since 1990. So
Right.
that's 33 years.
And you're a practicing psychiatrist.
Yes, I am.
And so when did you integrate light and emotional type of psychiatric disorders? When did that start?
Okay. I had been working with a way to stimulate the two hemispheres using a visual stimulation, and I wanted something more powerful. So I gave a cold call to the Wellman Center at MGH, and I got sort of passed around amongst some of the different PhDs, and wound up talking to a guy named Mike. And I had no idea who he was, and he seemed interested. And we got talking. We had several discussions, and eventually we decided to try a study. My question was whether I could use near-infrared light to stimulate one of the hemispheres and to activate a positive mind. And I had done some work with transcranial magnetic stimulation, but they always do that on the left side. And I found that the hemisphere that you should stimulate varies between people. It's actually about 50-50. So I wanted something that I could use in my office that might work. And I knew near-infrared light went through the skull. So my first question to the people at Wellman, including Mike, was, would this be safe? And Mike's answer was, if you don't hurt the skin, you're not going to hurt the brain because it gets, a small percentage, about 6% of the light. And so he felt that it was safe, and he felt it was a good idea to proceed with. And I didn't realize it at the time, but he was working with Marty Nesser with traumatic brain injury patients. And so he had some experience working with transcranial photobiomodulation.
And that Mike, just to let people know, that Mike is Dr. Michael Hamlin from Harvard, and now retired. And he can be quite enthusiastic, so I can see how you could be motivated.
Yeah. Well, and so he helped me do a study. We did a pilot study with 10 subjects at MGH, and we got really remarkable results with a single treatment. And we measured the Hamilton depression scores and Hamilton anxiety scores 2 weeks after a single treatment, and then at 4 weeks, and we saw a huge drop in the scores.
That's
amongst
fabulous.
the 10 people. Yeah.
That's
So
fabulous.
that was how we got off to this. And Mike directed me to the parameters of the device.
Excellent. So let's go with your presentation. Dual brain psychology for the treatment of addiction and other psychological issues.
Okay, so the first question that should come to mind is, well, what are we talking about with dual brain psychology? And I thought before I got into that, I would review some of the really remarkable results that we've gotten with photobiomodulation. And then I want to take you on a tour of dual brain psychology and show you its applications. It's useful, very, very useful for just psychotherapy. It has a whole theory of psychotherapy, and it's a theory of psychology that has clinical applications. And the main idea is that the two hemispheres each have a separate mind. And I think it's interesting because in psychiatry today, we don't talk about the mind so much anymore. It's all about the brain. And I think that the mind exists, and it has important effects on the brain. So if your mind is upset and seeing the world negatively, sorry, there's a message here. Did I lose you there?
No, here, right here, ready to go.
Okay.
When the mind sees things negatively, it's going
okay.
to.
I can't see you on the screen here. Can we pause it for a second?
Sure, hold on.
Wanted to the theory is that the mind is important, and that the brain actually has two minds within the same person. One that has been more affected by past traumas, and one that is healthier, but that the mind affects the brain, and it's the most powerful influence on the brain. So if you're feeling negatively, you affect the brain, and if you're feeling positively, you affect the brain in a positive way. So I want to go ahead and show some of the results that we got first, and then I'll talk more about dual brain psychology and how we got these results. So this is that I have, as you might mentioned, a company, Mindlight LLC, which is the recipient of a phase 2, $2.5 million grant from NIDA. It's an SBIR grant that McLean and Mindlight are going to conduct our phase 2 study. We have a breakthrough designation from the FDA, and the FDA has also made a determination that our device and method is of no significant risk. So I have a conflict of interest that I want to declare, and I have patents. So the idea here, this is an LED, it's a superluminous LED. It comes out at 240 milliwatts per centimeter square. And you can put it over either side of the forehead. And the idea is that if you put it over the positive side, you get a positive personality, and you put it on the negative side, the personality of the person changes. He's the same person, he or she, but as I'll describe further, there's a big difference in how I'm perceived. Um, um, and over here, I just list two papers, actually three papers that are published. One is, and I'm going to go over those quickly here. So the first one was a study of opioid cravings. We had 17 people come in 3 times. The first time they got either an active or a sham treatment, and the second week they got the opposite treatment, and the third week they just got a follow-up. And you'll notice Mike Hamlin is a co-author here. And what we found was that a week after the treatment, there was a decrease in cravings of 55% in the active treatment compared to 18% in the sham treatment. The sham is the same light device, but it has a sticky that's metallicized, so it blocks the photons. And so this had a low p-value and a nice effect size. 0.8 is considered a high effect size. So this is a good effect size.
Doc, that was just 2 treatments. The third was just a
Yeah,
follow-up.
it was only 1 active treatment and 1 sham treatment.
Correct.
But it was within subject. It was a within subject study, which reduces the variability. It has some complications to it in that depending on which one you do first, that might affect the outcome. But anyway, this is the Hamilton Depression Rating Scale scores, and at baseline, it was 15. After sham, it went down to 13, and after the active treatment, it went down to 8.8, and that was highly significant.
What's normal? What would be like no depression on the Hamilton score?
Less than 15. So these people are not severely depressed, and yet they still, and they're not coming in for depression. They're coming in. The entry criteria was that they have cravings for opioids, and as in the original study where we had like a 52% reduction in the Hamilton score, here we've got a similar big reduction, and so that I know from my practice where I use this that this is good for just about any psychiatric condition that I've run into.
And it does show an increase in positivity. So let's say they weren't depressed, but they appear to be more positive, as you stated, right?
Well, they're less depressed. This is a depression scale. And so a remission would be somewhere around here, around 7. Some people use 10, some people use 7. So this is really saying that they're in remission. And there's sort of an area between here and here where it's sort of undefined, but 15 is considered depression. So they have some mild depression, and it goes down to really not being depressed with the treatment. And again, that was not really a purpose of the treatment.
Secondary outcome.
Yeah. And then this was with anxiety. Again, this was the baseline of 14.7. Again, 15 is sort of the cutoff, and it goes from 14.7 to 14.3 after a week after the sham treatment. A week after the active treatment, it goes down to 8. And so that's, so they're much less anxious and and depressed, even though they didn't come in with severe anxiety or depression. And this is just showing that if you compare the positive side with the negative side with the light on, there's a significant difference in cravings. It's much higher on the negative side than on the positive side if you simulate it with the light on.
That was
If
asked.
you have the light off,
Mhm.
there's no difference.
And this is asking them at that moment, do you
Yeah,
have cravings?
that's right.
And they're saying no to a very significant effect. I have less cravings, type of thing, right?
The difference between active and sham was 0 when the light when with the sham treatment.
Correct.
The difference between the left and right hemisphere, the
Mm.
positive and negative hemisphere, was no different with after the treatment. But with the active treatment, there was a significant difference.
Nice.
So it's just saying that if you treat the negative hemisphere, you get a poorer response, you get more cravings than when you treat the positive hemisphere. And the main outcome of this study was that we had a 52% drop in cravings. So then we got a phase 1 study from it's an SBIR grant from NIDA, and McLean did a large portion of the study, and Meinleit did the other, and so this is the idea. We decide which hemisphere is the positive hemisphere, and we put the light over it for 4 minutes. It's a 4-minute treatment, and it's interesting. I'll just sort of say a little bit about this. If I put it over the negative side, I look critical, and they tend to not like themselves, and they start getting drug cravings, and so it's like a whole world view that changes. That's why I say it's of two minds. In other words, it's not just that they feel a little better; their perceptions are different, their actions are different. They're more likely to use. Out the positive side, I look supportive. They like themselves more, and they feel more confident, and they would never use. Or you know, their desire to use goes way down. So in the study, people came in for twice a week for 6 weeks. So this is the end of treatment here, and these are 3 follow-ups. And this is the active treatment. And you see that this is the cravings minus the baseline. So you see that there's a decrease in cravings of down here. It's actually 5 points on a 10-point scale. And when we actually look at the beginning to the end of the percent difference, amongst people who were not on Suboxone, there was an 80% decrease in cravings in the actively treated group. In the sham treated group, at this point here, it's about a 1.5 decrease. And it was highly significant. It had an effect size of 1.5, and the p-value was 0.000.
Outstanding. Outstanding.
And then this is to show that we got very similar results. There was no statistical difference between what McLean found and what we found at Meinleit. So it's a 2-site study. And again, they got treated twice a week for 4 weeks with 3 follow-ups. And then this shows that people without buprenorphine, as I said, had an 80% decrease in cravings between this point and the beginning. But people who were on Suboxone had a 65% decrease in cravings and was significantly better than the sham. So even though they were on Suboxone, they still got a big benefit out of this light treatment, twice a week, a 4-minute light treatment. And then this shows that at McLean, there was a big drop in use. We didn't see that at MindLight. And when we published the paper, I didn't understand this, and Dr. Teicher at McLean didn't. And then the FDA was curious about this, and they asked me some probing questions. And what I found was that at McLean, it turned out that there were only 10 people who were using on entry to the study, and 5 were treated at MindLight, and 5 were treated at McLean. And at MindLight, 4 out of 5 got the sham, and at McLean, 4 out of 5 got the active treatment. And so that's why McLean did well in terms of use. And in terms of use overall, there was a big difference. This shows a decrease in use in the active treatment and some increase in use in the sham treatment. And this shows the difference in days of use. So there was a decrease in days of use of 98 and a decrease in days of 9 in the sham. And this shows that the Hamilton depression score in those who were not on buprenorphine decreased, but in this group, they were really had a very low Hamilton score. So to get any decrease is impressive. And this was almost significant, but not quite. But it was a small sample. And with anxiety, it was significant at 0.0018. But again, the anxiety score baseline was also low. So even though it was low, there was an average of a 3.5-point drop from that. So it became very low. So it's not only treating cravings and use, it's also treating anxiety and depression. And so that led to our getting a phase 2 grant when we're just beginning that study now, or we're about to begin it. And we have a breakthrough FDA designation. So in order to understand what we're doing, I'm going to have to talk about dual brain psychology. And as I mentioned a little earlier, dual brain psychology posits that one brain hemisphere is associated with a mind that is more troubled, and I find by past traumas, usually complex PTSD, and that the other mind is less affected by that and is healthier, and that mind probably develops later in late adolescence, early adulthood. So this is a whole paradigm shift. No one that I know of is thinking about the hemispheres having minds and the minds being important, having important effects on the brain. And so that the usual ideas today are psychopharmacologic treatments, and treatments are given on a daily basis for years. They have very low efficacy, and that they relieve a presumed primary pathological brain state, but that pathological brain state is really unclear after trillions of dollars and 4 decades of study, and that the standard of treatment today is not dependent on the patient's psychology generally. Of course, there are people who are interested in psychology, but in psychiatry, we've sort of lost our mind a bit. So in dual brain psychology, we think of trauma and psychology are primary, and that they affect the brain, and that neuropsychiatry is grounded in whole brain hemispheres, actually half a brain. But what it's saying is that that in patients who have a hemisphere removed for cancer, they're still a human being. If you start taking more away, then you lose that. So there's something about a hemisphere that does enable a mind to appear and to come up. And there's what's called a WADA study, in which neurosurgeons do this before surgery to determine which side language is on, to make sure it's on the left side so they don't injure the language during usually epilepsy surgery. And what the WADA test does is I lost my screen again here. You want to pause? A whole hemisphere. So if you remove a whole hemisphere, you have an intact person. If you lose more than that, you don't. So that the intact hemisphere can support a mind. And this comes out of the groundbreaking Nobel Prize winning split brain studies that I'm going to talk about. So all this began when, as a young psychiatrist, I was interested in Freud and went through my own training. And I didn't, not a training analyst because I didn't go through that, but while I was a resident, I went through psychoanalysis and so I know what an id and ego and superego are and parts and archetypes. But what I was seeing in my patients really was two minds, that when they were doing well, they were like a different person. When they regressed, they became like an immature person. And then I came upon the split brain studies, and I was in England and on vacation with my family, and I was reading a book on the split brain studies, and I saw that this might be related to my observations clinically. So these are the leaders, Joe Bogan, Roger Sperry, who won the Nobel Prize, and Iran Zaidel. And the idea behind the split brain studies is if you cut the corpus callosum here, you have two separate minds, and you can talk to the left brain. And if you show an image over here to the left visual field, it hits the retina because of the lens. On the medial side, the retina is divided vertically, and this goes over to the right brain. So the right brain can see it. The left brain can't see it. And so the person will tell you, well, I can't see it. I don't know what it is. But the right brain is not able to speak, but it can reach into the box where there are 10 items and pull out the correct item. So it understands English, understands what you're asking of it, and it knows how to pick out the right item. The left brain can use its right hand, which is connected to the left brain, and it can't pick out the item. So this I'm trying to give you an idea that these two hemispheres have different, actually have different minds. they're the same person, but they're different. So Sperry showed a female patient a picture to her left brain. It was only seen by her right brain, and she started giggling. And she didn't know why she was giggling. She had no idea, because you're talking to her left brain. Only the left brain can speak. And so this is what Sperry did. He showed a Playboy nude, and her right brain thought it was very funny. It was in the 1960s, and I guess they were the Mad Men days, and so that was. It might not be funny today, but it was funny at the time. And so the right brain it caused the woman to laugh, and the left brain had no idea why she was laughing. So one patient was shown a picture to his left brain, not to his left visual field. So only his right brain saw it, and he gave a thumbs down with his left hand, and it was a picture of Hitler. Roosevelt got a thumbs up. Another patient wanted to be a draftsman with his left hand, and his left brain said, I have this backwards. His left brain said he wanted to be a draftsman, but his using Scrabble chips, he was the only patient who was able to do this. He was able to spell out a race car driver when asked what he wanted to do. And then there's a post-coma sterotomy syndrome, which is really interesting. The two hands connected to these two different minds want to do different things. One patient wanted to smoke, and every time he lit up a cigarette, his other hand would put it out. His left brain wanted to smoke, and his right brain wanted to put it out. So there really is a sense of two minds. And so Sperry had a setup that he used where he could put a different word on each side of the screen. And so the left brain sees the word brush, and he says brush, but he's not able to reach behind the screen with his left hand and find the brush. But his right brain sees the word tooth and reaches behind and picks out the tooth. So I use a similar protocol to do a study with Joe Bogan and Iran Zaidel in 1998. And I did actually, it was the last split brain study in the California series. And it was the first to do a in-depth, I say in-depth, a psychological inventory. So I had different words appear on the two sides of the screen, and then the two hands would point to pegs. There are actually 5 pegs from none to extreme. And so I ask, how much do you feel? And the right brain is asked, how much do you feel happy? And he answers with his left hand, which is connected to his right brain.
Got it.
And his left brain sees the word dishonest, and both sides get all of the questions. And it turns out that we got very consistent answers in both patients. In one patient, his right hemisphere responded to positive words. 5 is the highest with a score of 4.2, and was lower on his negative things like dishonest. His left brain, however, was high on negative words and low on positive words. And so we concluded that that patient had a positive right hemisphere and a negative left hemisphere. Second patient had similar results on both sides, except that when we were setting up the equipment, he mentioned, I asked him about his past, of course, because I'm interested in that. And he mentioned that he was bullied as a youngster in school. probably because he had the seizures. And I asked him if that bothered him, and he said, "Of course not. It happened so long ago." And so I threw in about 7 bully questions, and the 2 hands answered, and his left hand answering, his right hand answering for his left brain, which told me he was not upset, indicated he was not upset by the bullies at all. But his left hand signing for his right brain indicated he was extremely upset by the bullies years later, which I know to be the psychological truth. So this is a picture of a German scientist, Werner Wittling, and that's a device that he had constructed. And what he reported was that in normal people, he was showing movies to one hemisphere or the other. And it was I think a movie of people getting shock treatment. And I thought this was impossible because you've got the corpus callosum in these people, and what you show to one side should go to the other side, and you shouldn't see a difference. And but this is what he reported, and he also reported that all the bad stuff was not in the right brain, which is what I was expecting. I had written 2 papers saying the right brain must be the bad brain. And so I decided I couldn't afford his $1 million contraption, but all he was doing was showing the movie to the lateral visual field. And I figured on my budget, I could do that. And so here's, if I can get this to go. I can't, let me show you. Oh, there we go. Okay. So this is how I decided to do it. It didn't cost $1 million. And so I went to the office that day, and my first patient was a Vietnam vet who this was in the 90s, who had severe PTSD, both in childhood, and then he had 4 tours of duty, had a Purple Heart, and he looked at me. Excuse me. I'll plug in my power cord here. So he looked out the left visual field, and no, actually, he looked at the right visual field, his left brain. He activated his left brain, and he said, "That plant behind you looks like the jungle." So it's clearly a flashback to his PTSD. And I said, "Well, look out the other side." And he smiled and he said, "No, it's a nice looking plant." And I see this every day. This is what dual brain psychology is about. So he's just using his hands. Then I started using these taped goggles, and getting these remarkable differences between when a person looks at one side versus the other, and they're symptomatic on one side, and the symptoms tend to go away on the other side, and this is true of 80% of my practice, and about 55% have really intense responses. And so this is again the same graphic of the idea that there are different minds in the same person. And so here's a very evil sadist on one side, and here's a supportive psychiatrist on the other. And I have a book that has transcripts from therapy sessions using the goggles. And this is just a graphic showing that there can be a continuum between the two sides, and they can fight for dominance. And so you can wake up in the morning in a miserable mood and be filled with anxiety, and by the afternoon you feel better. And I think what happens is there's a shift in your dominance. The two sides can fight amongst each other, sort of like Steve Martin and Lily Tomlin did in the movie of
The Man with
Steve
Two
Martin.
Brains.
No, it was another movie. Martin made two movies like that. It was called The Two of Us. And so he goes out to the street in Manhattan, and he wants to go north, and Lily Tomlin wants to go south, and Steve Martin is the embodiment, and he's going like this. And it's very funny, but it's true. So we've got about 30 papers now on this research. So these are peer-reviewed papers in really good journals. And Candace Pert, who died a few years ago, wrote Dr. Schiffer rivals Freud in his revolutionary theories on understanding of the human psyche. And Joe Bogan, who I became friendly with, worked, he was a neurosurgeon who collaborated with Sperry, wrote wonderfully readable, well-informed. This is the best book ever on the social and psychiatric implications of the split brain research. And these are a list of my papers, which you can see on my website, DBP for Dual Brain Psychology, institute.com. There we go. Okay. So this is a study. So we've done, so what these studies are that I mentioned are studies like this, where this is an fMRI study of 7 people from our lab. Dr. Teicher and I are included in the 7, and we wore those goggles in the scanner. And the instructions were look to the left for 30 seconds, look to the right for 30 seconds, and then repeat it. And then if you look at the individual data, you don't see much. But if you look at the crunch data for the 7 individuals, you can see that when you look to the left, you are actually activating the right brain. And when you look to the right, you're actually activating. This is an fMRI. It's a functional fMRI and measures blood flow. And so you're actually activating the left brain when you look to the right visual field. And again, the visual field is half of the eye, not the whole eye. So this is a study that we did. This is an anatomical study. We measured using a computer test which side was positive. So if you had a positive left brain, your nucleus accumbens was larger, your amygdala was smaller, and your hippocampus was larger. This was done on 50 subjects. Another study here showed that with TMS, they always treat the left side. And I suggested that they treat the positive hemisphere with TMS. And I've never been able to get any TMS person, including the companies who make it, to do this, because I think it would increase the efficacy by 50%. And so I predicted that if you stimulate with left-sided TMS, the negative hemisphere, you're not going to do well. If you stimulate the hemisphere, the person will have a good outcome. So here's a study I did with Alvaro Pasqualeone in around 2000, when it was still a research device. So these people here are down is an improvement. There was one woman here who was left-handed and had a good improvement, even though she had a positive right hemisphere and a negative left hemisphere. All the other people failed. They had less than 20% decrease, with 2 exceptions. This group here was the positive group, and they had an average of a 45% remission rate, which is quite good. Usually, the overall is much less than that, and today it's about a third of people go into remission with about 3 weeks of treatment and follow-up. And the treatment difficult. You have to go in 5 days a week and listen to this jackhammer. So it's not toxic, and it's not really invasive, but it's inconvenient and a nuisance and expensive. So I tell people to get your equipment, and instead of the goggles, I now just use a piece of junk mail and just have them block one eye and half of the other, sort of like this. And so this is a guy who I had treated for cocaine abuse a few years earlier. And when I discovered this lateralized difference with the visual fields, I had the patient come back, and he had been treated for, as I said, for cocaine abuse, but was due to his father's contempt for him. So I asked him how he's feeling, and he says anxious because I can't. He's looking at the negative side because I can't see what's coming at me from the other side. And I asked if it's familiar. He says sort of familiar because I'm in business, and you never know what's about to happen. Definitely unknown. And then I asked him. Excuse me. To try the other goggles, and he says, I think less mild, and he says more relaxed from this side. The other side, I'm more uptight, so then I asked, I said, can you relate these uncomfortable feelings to your father while he's looking out the negative side? He says, I don't know. I was never comfortable around my father. With these glasses on, it's sort of like dealing with him again, and because it's always the unknown. It's always a pressure and a problem. You feel the unknown, you have the tension. And then I ask when he's looking at the positive side, and he says, I can deal with him on this side. And this is within a few seconds, the difference. And he said, I know I can handle him now. I don't think he'd get me upset. And I wouldn't do the counterproductive things if I looked at him at this side all the time. I'd feel more pity for him and for the relationship. And I don't think I'd want to abuse myself by using drugs. And this is typical of people who respond strongly. In other words, it's a whole mindset. This is why I'm saying of dual brain, it's really dual mind. Okay. And so here's an audio. I don't know if it'll play one here.
I think you got to go back to your pointer, and if you want to turn it on.
Okay.
Go ahead, play it. Let's see.
How does she look?
Mad.
She's looking at a photograph of an angry woman.
Feel a little anxious looking at her. She's definitely looks pretty angry.
So say from 0 to 10.
Probably about 8.
So let's do the last time.
Yeah.
Hold it.
Yep.
So this is okay. So this is with the light device.
This is actually the time of the treatment. You're actually putting it
Yeah,
on her
yeah.
left forehead, just like this.
I'm putting it on her positive forehead. I don't know. I said left side. Okay.
Mhm.
So, but an individual person, I don't know whether I'm going to wind up treating their left or the right side. So the common belief that the right side is the side of all the pathologies is, in my view, not correct, not from my observations. So let me speed this up a little bit.
Not as,
So I'm just speeding it.
really doesn't scare me or anything. It just
She's talking about the picture.
doesn't look like she's yelling at me anymore.
Now, her mother yelled.
She's kind of making a crazy face.
How much anxiety?
Lay down to like 5 or 6.
That was 8
I think I'm
before.
normally living at like a 4 or so.
So she's still being treated. So 4-minute treatment.
Compared to regular anxiety.
You said your regular anxiety is around 4,
Probably. Right. Well, I mean, I think I don't think I could get much lower than 4, is all I mean. Just naturally living and so it is a little bit higher, but not much. I mean, right now I think it's probably at a 4. But she doesn't look angry anymore. She's just kind of grimacing or whatever. It's like just a.
How are you feeling about yourself?
Okay. Not as depressed, maybe. Feel okay about myself. I don't feel great, but I don't feel, terrible either. Just better. Yeah, I do. I feel okay. Just okay. Not
Which is an
angry at
improvement.
myself right now, basically, which is usually how I would describe my feeling toward myself. Just like anger and disappointment, and I don't really feel that right now.
And how much is from the session we had? How much of you was from the life?
Maybe 50-50. I can't.
No, that's good.
It's hard to tell. It is.
The light seems to.
Yeah, the light definitely changed the mood I was in. I mean, I was in tears, and now I'm not. I feel better. So.
Okay, and again, the intervention is we're stimulating one hemisphere. And then this is another patient. Do we have time for this or?
Certainly.
Okay. Let's see. So his left brain is positive, and in 4 minutes. I'm confused about what the instructions here. Let's see what we got.
Okay, so I'm not gonna have you look at any picture. I want you to tell me right now, before I treat you, tell me what you're feeling.
I feel angry. Yeah, I feel emotionally crushed. I feel sad. I feel like I don't know. I just I feel. I feel like I got a knot in my stomach and
Mhm.
a ball in my chest.
Okay, and it's just kind of sort of like an objective measure. How hopeless do you feel, say from 0 to 10?
I'd say I feel like a 5 right now.
What's the most intense feeling?
That I that I have felt
What's your feel right now?
right now is it's just like the overwhelming sadness and sadness comes to the anger that he's
So sadness and anger.
yeah.
And then how do you rate those between 0 and
Yeah,
10?
I'd say the sadness is like 8, my anger, which is really just fear of not getting through this, fear of not having my father, fear, it's like, that's like 12.
Okay. So let's see, which side we did.
Oh, we did this side. We'd always do this side.
We're gonna do the right side. Let's just check with this here. See which side you feel a little bit. Envelope.
So we do an envelope test to make sure we're in agreement.
Does that feel? You're looking at the left hand, the left.
Yeah. I get that little, that's not my stomach is there.
Is it worse or better?
It's there, it's not on a little. It's definitely not better.
And try the other side.
He's playing, Doc? It's playing?
Oh, yeah, it's playing. Let me speed it along here. Then I give him a light treatment.
Okay, so I'm not gonna have you look.
Side.
Yeah.
Hard to do it when,
When you're drowning on the outside.
um,
So how much sadness do you feel?
I'm still sad.
Mhm.
5.
Mhm. And anger and anxious.
The anger is definitely, definitely dissipated to, substantially,
You're doing enough.
probably like, like a 4, 5.
By the end of the treatment, he's feeling quite good. So I can move it up a bit.
And so he's taking over, so you feel hopeless and helpless the way you felt then. And so
He had a lot of trauma as a child.
you're here now, the way your father is,
Yeah.
that you're not alone. That he's not alone. It's interesting, isn't it?
And that's definitely is.
And his voice is a little different.
How's your chest feeling?
slight though. Good amount.
In terms of variables.
Bearable.
Yeah, I still feel miserable, but I mean, it's not like,
Ordinary miserableness, right?
Yeah.
Crushing miserableness.
exactly, yeah.
It's true, it's all.
Right, so this is a transcript from another patient. So you're looking at this angry man. Tell me what you're feeling. Feel scared. How scared from 0 to 10? I'd say 8 or 9. Now I notice you seem to be shaking. Now his leg was going up and down about an inch. Yeah, I know. It's not because I'm trying to do it on purpose. I know, but it's an example of how stressed you feel. Yeah, extremely stressed. Let's try to treat you. Then after a 4-minute treatment, I say to him, you're not shaking now. He says, no. What's your stress level? I would say 4. Less than when I walked in the door. I would say less than half of what it was before the treatment. Then it was a 10. So you know, it's not like one person who's responding like this. I do this all day long, and there really is there are two minds that come up, and if I put the light over the negative side, they don't get worse than their normal bad state, but they go into their symptomatic state. Let's see. Okay. So I think that's what I have here. So I think what I want to say is that dual brain psychology is the idea that we have two minds, and that one of them is traumatized, and we see that in these patient examples. And the other side is relatively stronger and more mature and healthier. And this is an observation that no one else has made. And all it takes is a simple envelope. And if you take that in your practice, you'll see the same thing that I see. It's not hard to do. Now, it has to be half of one eye like this. If you look out the whole eye, it doesn't work because the retina goes to both sides. And so compare one side with the other side and see how the patient, just talk to the patient. You'll notice that they're in a different state. And then what I do in dual brain psychology or dual brain psychotherapy is I treat the troubled side. I talk to it, and I help it to see the relationship between the early traumas and the state that they're in on that side. And then I try and get the healthy side to be a good parent to the troubled side. And sometimes to say, now get in the back and behave yourself. Because I've got to give a presentation now, or I've got to go to a meeting, but I'll talk to you later. And then other times be supportive, and that over time, before the patient comes to me, these two sides have been fighting. That the mature side has been suppressed and is angry at this troubled side that's kind of ruining its life, and so there's a hostility between the two, and so I'm trying to get the two sides to be like a good couple, or and also, I think of transference as being really the relationship between the negative side, the more troubled side, and me. And that's where, transference comes up.
But you know, Doc, you've done groundbreaking work, not only in the psychotherapy perspective, but also you add to it a therapeutic perspective that not too many people are aware of, which is not only transcranial photobiomodulation, but unilateral.
Right.
So a diagnosis improved, the diagnosis is improved and everything is improved and the results are life-saving. So you've
Right.
come up, and I can see how much work and dedication you've put in the last 3 years, and the things that you observed and predicted at the last summit, you've accomplished those. So I have to say, well done, and thank you for your contribution.
Well, thank you. Thank you, sir.